Colleen Cook. I'm the Dean of the College of Medicine here at University of Florida. And on behalf of the college and UF Health, I want to thank you for joining us today. And thank you for the generosity of your gift. The Alpha Phi Foundation has been championing the cause of heart health for more than 75 years. That's a long time, and that's really incredible commitment. And we're honored to have been chosen for the 2023 Heart to Heart grant. This gift will help advance the diagnosis and treatment of heart failure with preserved ejection fraction, something that happens more predominantly in women. Philanthropy, as you know, really forms a cornerstone for our role here at the college in terms of research as well as in education, and we're very grateful for receiving this grant. And because of your generosity, we're going to hear a little bit more today about how we're going to be able to extend research to help women in advanced heart failure research that we can share with the country. So I'm going to introduce Dr. Jamie Conte, who is the chair of the Department of Medicine here at University of Florida, who's going to give you a few points. So thank you very much.
Thank you, Dean Cook, and thank you all for joining us here today to celebrate Dr. Ellen Keeley and her team, recipient of the 2023 Alpha Phi Foundation Heart to Heart grant. As Dr. Cook noted, this annual award supports the advancement of women's heart health and cardiac care. Ellen's work will focus on the study of women with heart failure with preserved ejection fraction, a difficult disease to diagnose, treat, and also to improve quality of life. Dr. Carl Pepin will be her co-investigator, along with Dr. Alani and Dr. Duarte, all of whom have a long interest in women's heart health. Many thanks to the Alpha Phi Foundation for their support of this very important work. Thank you all for being here. And then it's my pleasure then to introduce Susan Barrick, the past board chair of the Alpha Phi Foundation. Barrick.
Thank you. Good afternoon. It is so enjoyable to be here with my Alpha Phi sisters and medical people from UF Shands and Health. My name is Susan Barrick, as was said, and I am an Alpha Phi Foundation volunteer and also one of the initial advisors to the Kappa Eta chapter here on this campus when it was installed in 2018. The board and the staff members of the Alpha Phi Foundation are so excited to present this grant to our 2023 Heart to Heart grant recipients at the University of Florida Health. Thank you for partnering with us to advance women's cardiac care. Alpha Phi adopted heart health as our philanthropic focus in 1946, which is just over 75 years ago, and often in choice as the needs for funding that targets the care and education of women's heart health has continued to grow. In 1993, the Alpha Phi Foundation established the Heart to Heart grant to help lessen the gap in funding women's heart health. Since the grant's inception, we have invested over $1.5 million to fund groundbreaking research and educational projects across the country. Results from these projects are helping us all better understand, treat, and prevent heart disease for women everywhere. Today's grant is not $10,000, it is $100,000. 30 years later, our commitment to heart health for women is still growing. We are so excited to announce that the Heart to Heart grant will expand in its 31st year. In 2024, we will award both a $100,000 clinical research grant and a $25,000 community education and programming grant. This expansion of our grant process is due to the generosity of our donors, both alumni and collegiate. Today, I also recognize the 53 outstanding Alpha Phi alumni who volunteered as medical readers for the 2023 grant cycle. These sisters have expertise in the medical and research fields, and their unwavering dedication to awarding the Heart to Heart grant makes this all possible. Now, I am honored to introduce the University of Florida Health team and their research project, Hearts on Fire, Targeting Inflammation in Women with Heart Failure with Preserved Ejection Fraction, led by Dr. Ellen Keeley, in partnership with Drs. Carl Pepin, Mohamed Alami, and Julia Duarte. This is a novel cardiac MRI technique, and it will be utilized to inform further techniques and treatments for HFpEF, which is a highly prevalent diagnosis in women, and I'm sure we'll hear more about this soon. This project joins the ranks of an impressive history of heart-to-heart grant recipients and institutions such as the University of Pennsylvania, Duke University, UC Davis, and the University of Iowa. We are elated to add the University of Florida to this list of exceptional institutions that are changing the future of women's cardiac care for the better. Please join me in welcoming to the podium Dr. Ellen Keeley, Principal Investigator and recipient of the 2023 Heart-to-Heart Grant.
Thank you very much. Good afternoon. Thank you for coming. As was stated, our project is called Hearts on Fire, Targeting Inflammation in Women with Heart Failure with Preserved Ejection Fraction. And today what I'd like to do is kind of present the research that we intend to carry out with the generous Alpha Phi Foundation Heart-to-Heart Grant award. But before we do that, I want to give a little bit of background so we're kind of all on the same page of what we're talking about here. So heart failure. Heart failure is an extremely common, very significant disease that we see all the time in clinic and in the hospital. And for the most part, patients who experience heart failure complain of shortness of breath. And the shortness of breath usually starts with exertion, but then can progress to shortness of breath at rest. They have abdominal distension, swelling in their legs, swelling in their feet, such that they can't put their shoes on. They're very tired, fatigued, and their quality of life is very poor. So it's a very significant disease process, and it's extremely common. But before we talk about the disease process, I want to talk about the normal heart first. So this is just a little diagram of the normal heart, kind of a cross section, so to speak. And I want you to concentrate on two areas. This is called the left atrium. It's a chamber on the top part of the heart. But the focus of this whole talk is really this chamber called the left ventricle. This is the chamber that pumps the blood to the body, to the brain, to the kidneys, everywhere. And in a normal heart, the amount that left ventricle right here can pump out to the body is about 50 to 70% of the volume that's in it. And that's considered a normal ejection fraction. So when we say ejection fraction, all that really means is that the left ventricular's ability to pump out the volume that's in there, of blood that's in there. And that is half to a little bit more than half is the normal amount that it should be able to pump out. Now, in patients who have heart failure with reduced ejection fraction, there's two types of heart failure. One is patients that have a reduced heart pumping function, and one is the topic of our research was for patients who have a preserved pumping function. So first, let's talk about the reduced pumping function. So in these patients, the left ventricle, which is right here, you can see compared to normal, this ventricle is enlarged. It's too big. And the muscle here, compared to this muscle here, is a little bit thinned out. So this type of heart failure with reduced ejection fraction, R for reduce, this type of heart failure, the heart really struggles to try to pump blood out of the ventricle to the rest of the body. And the heart muscle itself is very weak. Now, the type of heart failure that we're interested in and going to study with this grant is called heart failure with preserved ejection fraction, P for preserved. And here, again, just to set us up, here's the left atrium, which is one of the top chambers, and here's the left ventricle. And you see, compared to the normal, this ventricle, the size of it inside, the chamber seems smaller, and that's at rest, it's already too small. And then the muscle here is thickened. So this type of heart doesn't struggle necessarily to pump the blood out of the ventricle. It struggles to relax enough to allow blood to enter the chamber. And of course, you can only pump out what is already there. And so these patients become very, very short of breath and have the very similar symptoms of patients who have reduced ejection fraction, but you can see there's two different etiologies going on. So this heart kind of pumps too well, but doesn't know how to relax, and therefore the chamber is small, the blood volume in there is small, and they end up with the same symptoms as someone who has a very weak heart muscle. Whether you have a preserved heart muscle or a reduced heart muscle type of heart failure, the bottom line is heart failure is associated with very significant morbidity and mortality. And this is information from a very large study following about 3,000 patients with heart failure. And on the vertical line here, this is the percent survival. And on the horizontal line here, this is the number of days that these investigators have followed these patients since their diagnosis of heart failure. The blue line is the patients with preserved ejection fraction, and the red with reduced ejection fraction. And as you can see, both of them are associated with a very significant amount of death at 1 year. So about 25% of patients in both groups in this study died within 1 year's time. And if you compare statistically this line with this line, there's no difference. So it's just the outcomes with preserved ejection fraction, even though it sounds good, like it's preserved, it's just as bad as the reduced ejection fraction patients. So the way we assess clinically ejection fraction is usually by an ultrasound of the heart, or called echocardiogram. And I'm going to show you three. The first one is normal. So the first one we're going to play this way. We're going to play this way. Okay. So this is a normal heart. This is the atrium, and this is the ventricle. This is the muscle of the left ventricle right here. And with each beat, you see that muscle kind of thickens up. Okay, now this is a side view of the heart. This is the left atrium, just like we saw in the other diagram. This is the ventricle. And you can see already, this is the patients with reduced ejection fraction. The ventricle itself, there's a lot of darkness here. This is where the blood would be, right here and here. And all of a sudden, you see that compared to the one we just looked at, which was normal, this muscle, number one, is thinner, and number two, the chamber is very large. So let me play this. There we go. And you can kind of get the sense that it's very sluggish. It's sluggish, and this muscle is weak. And this is the reduced ejection fraction type of heart failure. Now, this is the preserved ejection fraction. Again, left atrium, and this is the ventricle here. So already you see that the chamber, the darkness here, where the blood should be, looks smaller. It's smaller. It's actually smaller than the normal, much smaller than the one with the reduced ejection fraction. And the muscle here is thick, and it's even thick at rest. It's too thick. It's too strong, and it's stiff. And when we see it on echocardiogram, this is what it would look like. So again, very classic heart that can pump, but doesn't relax well, not enough blood in the chamber, not enough blood fills inside the chamber in between each heartbeat, presents in the same fashion as the patients with reduced heart failure. When we look at the reduced versus the preserved heart failure data, we see another really interesting thing, and this is one of the focus of why we think this is important and why we think this is an important women's health issue. That this is information from a study that looked at the number of cases in the community of heart failure. This is the reduced ejection fraction heart failure. And they separated the patients into men and women, so the men are in the purple dots and the women in the orange dots. And then they also separated it according to age group, so 25 to 49, 50 to 59, etc. And as you can see, in patients who have heart failure with reduced ejection fraction, as to be expected, it slowly increases
over our lifespan, the chance of developing this. And then also, more importantly, for the most part, it affects more men than women. You can see the purple dots here. Now let's compare that to heart failure with preserved ejection fraction. So here, same thing. This line here, the vertical line is the prevalence, the number of cases in the community. And this, the horizontal line, is the age groups. The men are in the purple dots, and the women are in the orange dots. And you can see that it's flipped. That number one, this is primarily a disease, although men can develop heart failure with preserved ejection fraction, it's primarily a disease of women. And also really kind of skyrockets as women get older in age. You can just see the slope of this line is much steeper than here. So there's some characteristics that we see when it comes to heart failure with preserved ejection fraction. So now I'm going to concentrate just on that because that's the topic of our grant. And in general, patients with heart failure with preserved ejection fraction primarily tend to be women, older women. It's associated with obesity, and it's also associated with more cardiovascular comorbidities, meaning that patients who have heart failure with preserved ejection fraction also seem to have other things like hypertension, and diabetes, and atrial fibrillation. And in addition, they also tend to have non-cardiac diseases like anemia, and kidney disease, and COPD, and thyroid problems, and cancer. And so it's more of a syndrome, I guess we would call it. And it's a very, which makes it more of a complicated type disease process to study because there's multiple things going on. But everyone would agree that these patients are complex, mainly older women associated with obesity and lots of different comorbidities. So right now, this type of heart failure affects about 6 million people in the United States and Europe. And it's increasing very significantly. And it's estimated that by 2030, 8 million people will have this disease process. It's associated with very frequent hospitalizations for shortness of breath and swelling, leading to patients who come into the hospital for treatment for that, at least 2 to 3 hospitalizations a year. And within this type of heart failure, there's a very significant disease mortality, with almost half of these patients after diagnosis, or at least after their first hospitalization, dying within 5 years. So you can see that it's a very significant problem. It's associated with other medical conditions, which we discussed, and again, it's a very common form of heart failure in women. But here's the problem. There's few medications that help with this type of heart failure. Compared to heart failure with reduced ejection fraction, many clinical trials over the last 30 years probably have given us an armamentarium of different medications coming from different classes of different medications that have shown to not only improve symptoms in patients with heart failure with reduced ejection fraction, but also make them live longer. But the same cannot be said with this type of heart failure. So I think that this type of heart failure is where we were with that type of heart failure, reduced heart failure, about 30 years ago. So more treatments are needed. But the problem with the treatments is that you have to understand the biology or the pathophysiology of what's going on in order to figure out what the targets can be for the treatment. And so in order to develop treatments that are going to work for women, then we have to understand the biology of it more. And that's another problem. We don't know all that we need to know about heart failure with preserved ejection fraction. We don't know enough that we don't know a similar volume that we know with heart failure with reduced ejection fraction. So more studies are needed. But there's a few things that we kind of know. One is that in patients with heart failure with preserved ejection fraction, it's been shown in large kind of studies with large groups of patients being followed, that levels of inflammatory markers in the blood, like C-reactive protein and those types of things that represent an inflammatory process, are higher in the blood of patients with
heart failure with preserved ejection fraction. So that we know. We also know in very few studies, you can imagine, because they're biopsy studies, that in patients who have heart failure with preserved ejection fraction, if you take a little piece of the heart muscle and you look at it under the microscope, you will see inflammatory cells, more so than in patients who don't have this disease process. And then lastly, blood levels of omega-3 fatty acids, which are considered to be anti-inflammatory, so these would be good, are known to be low in patients with heart failure with preserved ejection fraction. And that is from data that's very well accepted. There's also some information from a randomized trial years ago that in patients with heart failure, those who were randomized to omega-3 fatty acids compared to like a sugar pill actually did much better. So we're very interested, our group, in the omega-3 fatty acid side of things. Omega-3 fatty acids they're basically polyunsaturated fatty acids, and they're very, very important for the structure of your cells and the membranes and the structures of all the cells in our bodies. There's two main types, eicosapentaenoic acid, or EPA, you might see that in the low press as well, or docosahexaenoic acid, or DHA. Well, the interesting thing is we can't make them in our bodies. We have to ingest them. So we either ingest them by eating salmon, mackerel, bluefish, sardines, that type of fish, or by pills. So the one thing that we know is that we cannot produce them. But they're very important for our bodies, and so that's why it's the American Heart Association recommends, so many servings of salmon a week and that type of thing. That's where this information is coming from. So now to our heart-to-heart grant aims. We want to test whether women with heart failure with preserved ejection fraction actually have inflammation in the heart. And then we want to also see whether or not the inflammation is associated with lower or higher omega-3 fatty acid levels. So before we dive a little bit more into that, I just want to go over two things. One, the first thing is how the blood flow in the heart works. This is the heart with the red lines here represent the coronary arteries. So these are large arteries that sit on top of the heart muscle. And what they do is they bring blood to the heart muscle that has oxygen and nutrients in it and feeds the heart muscle. This is how the heart gets its supply. And what happens is each of these arteries breaks down into tiny little microscopic vessels that go all the way through the heart muscle. So the whole thickness, whenever you see those cross sections, the whole thickness of that heart muscle that makes that chamber is being fed by these arteries. Now, once the heart muscle gets the blood flow and takes the nutrients and the oxygen from it, it has to get rid of it then. In order to do that, it sends it to the venous system. So this is the arterial system, and this is the venous system. This large vein in the heart is called the coronary sinus, and it's a very interesting place where all the blood that has been processed by the heart, and the heart is no longer moving it sends it to the coronary sinus, and then eventually this blood then makes its way back to the lungs to get oxygen, and then starts the whole process over again. So I bring this to your attention because if we measure blood sample from the aorta, which is the big blood vessel here that gives the blood to the heart arteries, or even inside one of these heart arteries. And we also sample blood from this vein inside the heart, which we can do in the cath lab, and we have done that. We get a glimpse of what the heart's doing. We know what's going in, and we know what comes out, and we can compare levels of things, whether it be omega-3 fatty acids or whatever you would like to measure, and we can see whether it's higher or lower once it comes out of the heart into the venous system.
We did this on a very small scale and found that in patients with heart failure with preserved ejection fraction, there seemed to be a difference across the heart. This would be called like a transmyocardial gradient. There's a difference across the heart in the omega-3 fatty acids, one of the omega-3 fatty acids. And that's what prompted us to use that as our preliminary data for the Alpha Phi Foundation Heart-to-Heart grant. Now, in order to do the proper research, we need to enroll more patients, and hence this is why we applied for the grant. But we have an idea here, and this is what we want to carry out. So what about the inflammation in the heart? So I mentioned that some of the studies have said that in patients who have heart failure with preserved ejection fraction, in their blood that you can get from the vein, so just a blood sample, they have high markers of inflammation. Well, that's interesting, but it doesn't tell us whether or not those markers of inflammation are coming from the heart or going to the heart or associated with the heart at all. So, and the 1 or 2 studies that have done biopsies on patients and looked under the microscope to see inflammatory cells are very interesting and it's thought-provoking, but it's only a few studies. And of course, we can't biopsy patients who we think have heart failure with preserved ejection fraction to really find out if they have inflammation of the heart muscle. So this is an example of a piece of heart muscle here that when you look at it under the microscope, this is the heart muscle itself, the cardiac myocytes here, and then all these little purple dots are inflammatory cells. And if you take one of these purple dots and you magnify it, this is the type of inflammatory cell that we're most interested in, and it is called a macrophage. And we're all born with macrophages in our heart muscle, and their job is to keep things quiet, to clean the mess up. Whenever they see a cell in the heart muscle that doesn't appear to be healthy or has died, it tries to gobble up that cell and get it out of the way. It also will gobble up anything that it sees as foreign. So it's a very interesting cell. We all have them. They remain in our heart over many, many years. And these are the types of cells that the other investigators found were higher in number in the biopsies of those patients. Now, if you want to try to figure out if there's inflammation in the heart muscle, we have done here, and there is a very novel MRI type technique. And what you do is the following. Remember how I said the macrophages will gobble up things that seem foreign to them. So if you give someone an iron infusion, just like you would for like iron deficiency anemia, the iron will circulate in that person's body. Several days later, you bring the patient back, you do a heart MRI, and if there is a lot of inflammation in the heart muscle itself, all those macrophages will see that iron and gobble it up. And then what will happen is, because that iron has magnetic properties, it will light up, so to speak, on the cardiac MRI. So this type of iron MRI, heart MRI technique has been used in patients who've had a heart attack. Well, you can imagine if they've had a heart attack, there's all kinds of inflammation in the heart muscle. And it's been used in several other heart conditions. But to my knowledge, this very moment in time, it has not been studied in patients with heart failure with preserved ejection fraction. And the whole concept behind this type of heart failure is that the paradigm is that it's really driven by inflammation. So we want to see whether or not we can pick up inflammation in these patients' hearts. So what we will do is we will sample the blood from the periphery, from the aorta, after it leaves the heart and it's all oxygenated, and then also from the coronary sinus, that area in the heart that takes what the heart's already used up. And we will measure the inflammatory markers, omega-3 fatty acids, and a whole panel of things that way. And then in these same patients, we will administer an iron infusion, which takes about a half hour. And then we monitor them for about an hour, make sure that do well with that. And then 3 days later, they come back to our McKnight Center and we do a cardiac MRI. So we're actively enrolling. We actually enrolled our first subject just last week, and she came in, she had an iron infusion, did fine, no problems. 3 days later, had a heart MRI. The images look beautiful, and so we're really excited. So we're on our way. We already have one patient completed, and we have at least 2 more who have already mentioned to us that they want to join the study. So I think that we're in a good shape to meet our enrollment plan goal, which is about 20 patients or more, hopefully over the next 2 years. So I think that we have a good team with Dr. Pepin and Dr. Alani and Dr. Duarte with our research coordinators, Sarah, Nicole, and Danya, who've already helped me get this patient their iron infusion and their cardiac MRI. So I thank them very much for that. And in addition, this summer, we're excited to add one more person to our team, and that would be a UF undergrad Alpha Phi member who's interested in doing clinical research. We have the position opened, and we'll be discussing that in more detail as the months go on, for a summer internship to kind of join us and see what it's like to do clinical research. It's be a great experience.
So on behalf of the entire Foundation Board of Directors, our Heart to Heart Advisory Council, which is a group of volunteers that helps make our Heart to Heart grant selection, and all of our staff, thank you so much for joining us today in celebrating Dr. Ellen Keeley and the University of Florida Health as our 2023 Heart to Heart grant recipient.